Thank you for your kind introduction, and thanks to the organizers for the opportunity to be here today. It's been a great symposium so far. I'm in awe of how much information has been presented so quickly. I can't talk as fast as Mike Cohen, but I'm going to try to get through my slides. My topic is clinical approaches to management of syphilis, and an alternate topic is the many faces of syphilis. Syphilis has been closely linked to the HIV epidemic since the beginning of the epidemic, but I don't think we've made nearly the kind of great progress that we have in terms of dealing with HIV per se. These are my disclosures, none of which are going to impact my comments today. This is an outline of what I'm going to try to do, and I'll apologize in advance for making at least my epidemiologic slides be United States-centric, but those are the data I know best. Watching the earlier presentations today, I also know that what's going on in North America parallels what's going on in much of the rest of at least high-income nations. Syphilis is a disease that is well known to clinicians, at least the word syphilis is, the idea of the infection. I'm now, I don't feel like I'm that old, but I now am in the second syphilis epidemic of my career. We've had multiple syphilis epidemics. We've had multiple commitments to eradicating or controlling syphilis, and each time we do, what we have to start with is relearning the disease. And so that's what some of my comments will be about. From a global perspective, it's important to realize there are nearly 20 million cases of syphilis occurring every year. No matter whether you live in sub-Saharan Africa or a higher income nation, this disease is most common in people with limited access to care, those on the margins of society for economic or social reasons. It's also globally the leading preventable cause of adverse outcomes of pregnancy as an infectious disease. In North America, as I hope to show you in a moment, we have a series of recurring epidemics, and as I alluded to earlier, in the United States, we've sought to and set out to eliminate syphilis on at least 3 separate occasions, and on each time, with the allocation of resources, we've had dramatic success in reducing but not eliminating the disease. Those efforts, however, have never been sustained, and as a result, the disease reliably comes back. Genital ulcer disease, as we've heard about earlier today, is an important driving force for HIV. I'll comment more about that in a moment. Syphilis is a diagnostic challenge. Well over 100 years ago, William Osler said, "No syphilis and all of its manifestations and all of medicine will be known unto you." About 40 years ago, Ed Tremont said, "No HIV and all of its manifestations and all of medicine will be known unto you." These two diseases are both protean, and I think that's important. And so part of my efforts today will be to sort of talk about the variability of this disease. Syphilis is indeed a driving force for the ongoing epidemic of HIV. And lastly, and most importantly, I would suggest to you, and I'll come back to this as well, I think the fact that we still have problems with syphilis and that we have an ongoing epidemic of syphilis is a public health embarrassment. This is the CDC's data on syphilis in the United States. You can see the disease was common, and it already started to decline, I would point out, before penicillin had become widely available. Rates declined. We had minor epidemics in the 70s with diseases that were more common in men who have sex with men than in heterosexual men and women. Then in the late 1990s, the epidemic shifted and involved heterosexual, largely drug-using minority groups. Again, intervention succeeded in dropping those rates substantially until just recently when rates have started to go up again. The most recent epidemic of syphilis is disproportionately occurring in men. but the rates are now beginning to go up again in women. And we've talked about, and several of my colleagues in their comments today on the sidelines have also mentioned the fact that in other nations we're also beginning to see congenital syphilis, which is an absolutely preventable problem. And again, yet another public health embarrassment. In 2016, there were about 600 cases of congenital syphilis. I understand from colleagues that here in the United States will be over 1,000 cases this year. So this epidemic, which is currently disproportionately affecting men and disproportionately affecting men who have sex with men, is now moving into the heterosexual population in North America as well. The current epidemic, however, is absolutely and completely centered amongst men who have sex with men. And one of the distinguishing characteristics about this epidemic for us is the large proportion of men who are acquiring syphilis who have HIV diagnosed at the time of their infection. And that raises questions that we've been dealing with for, again, over 20 or 30 years about whether or not the natural history of syphilis is changed by HIV. I'll comment more on that later. But let me also point out that syphilis, and Mike Cohen mentioned this, is an important driving force for newly acquired HIV infection. Currently in the United States, about half of men who are diagnosed with syphilis have HIV, but what people don't emphasize is that the incidence of HIV following a diagnosis of syphilis in people who do not have HIV at the time of diagnosis is 3 to 4% per year, and over a 10-year period approaches 20%. That sort of HIV incidence approaches the incidence that was used in populations where PrEP was proved to be highly efficacious. We're about to get into a bunch of pictures regarding the varieties of shapes, manifestations of syphilis. But before I do, I also want to say that one of the consequences of our recent epidemic of syphilis amongst persons with HIV and the high incidence that's occurring in our HIV clinics is that we have to revise our understanding of the natural history of this disease. This is the way it's taught. You're exposed, you get primary syphilis with a lesion, then most people get secondary syphilis, then those lesions spontaneously revert and go away, and then people only have a positive blood test, so-called latent syphilis. Well, I think that's probably incorrect, and what we're learning more and more, again, as we see incident cases in our clinics for persons with HIV, is that there is often an early latent phase of syphilis between the primary and secondary stage of infection. That's important because I think a reality in terms of the way public health practitioners often approach it is that when patients have latent syphilis, even early latent syphilis, for better or for worse, they do not put the same sort of energy into partner notification and control efforts that they might put into patients who have primary or secondary lesion syphilis. So what about those lesions? There it is. You will see a number of slides. Let me point out that when you see an ungloved hand, that's the patient's hand. I do wear gloves. This is a classical chancre, okay? A classical chancre in that it's painless, it's located on the distal portion of the penis, it's got a clean, indurated base to palpation. Most chancres are single, solitary lesions of this sort. But they're not always that way. Here are more primary chancres, at least 3 in this man. And more importantly, I want to point out that as I show on these 2 classical chancres, that when you do diagnostic testing for classical chancres, the majority of those lesions are caused by the herpes virus, which Dr. Patel will be talking about later today. So that we need to be aware that not only are syphilis and HIV closely linked, but primary syphilis and herpes are closely linked as well. At the time these lesions are present in patients with syphilis, patients are bacteremic with T. pallidum, the bacterium that causes this disease. Those manifestations then become apparent in the secondary stage of disease, in which the treponemes that have spread during primary syphilis manifest themselves clinically. The classical manifestation of those lesions are skin lesions, classically occurring on the palms or the soles of the feet. They're painless. Many people are not aware of them, and the clinicians who are evaluating patients with and at risk for syphilis need to be sure to examine those places for looking at them. But syphilis was called the great imitator, and so the palmar and plantar rashes of syphilis are not necessarily those painless lesions that I just show, nor are they always lesions on the palms or the soles. This was a college student who was seen 3 times before somebody got his RPR, which was positive of 1 to 256. His earlier diagnoses were that he had a viral infection or he was allergic to his laundry soap. The steroids that he received did not help him. Pityriasis rosea is a dermatologic condition that dermatologists are familiar with, internists see on a regular basis. It's described as a rash that has sort of a Christmas tree appearance. I think if you stretch your imagination, you can see the branches of the Christmas tree distribution here. This man was diagnosed with pityriasis rosea until he had his RPR, which was strongly positive. And these skin lesions can take almost any appearance. This is another skin lesion of secondary syphilis. I think, again, the thing that keeps humbling me in this disease is the remarkable diversity of these lesions. Here's a patient whose secondary lesions are occurring both on the penis and on the leg. Or lesions like this, which are called condylomata lata. I've seen these lesions misdiagnosed by people say, and in fact they do look a bit like genital warts, but genital warts did not appear in 2 weeks, and condylomata lata do, and that's part of the tip-off. But I think astute clinicians often are perhaps not attuned to that, and as Dr. Bacuzzi talked earlier today, sometimes clinicians get their laser focus, they're intent on what they're telling their patients they have without perhaps taking a full history or listening to why they came in the first place. Syphilis lesions can occur at any mucosal surface, so indeed we do see syphilitic lesions occurring on the tongue in various sizes and shapes, and on the lips. So again, this is a disease that keeps humbling us as clinicians. Any disease that can occur as a rash can occur almost anywhere. This is a patient we saw in the hospital. He'd been admitted. He was wearing a hat in the hospital, and so I asked him why he was wearing a hat, and he said his hair had been falling out. This is his rash of secondary syphilis involving follicular involvement by Treponema pallidum. And then finally, my last clinical slide for the great imitator is this man. I hope you can see it. It looks like he's got a Mike Tyson tattoo, doesn't it? He's got this rash on the top of his head. It went away when his secondary syphilis was treated. So I think a quick tour through the variability of syphilitic lesions I presented in my efforts to sort of encourage that we have to always have a high indication of suspicion as we look for this disease, because if we don't, we will miss it. So what about diagnosis? And diagnostic tests for syphilis are another topic that most medical students and healthcare providers have heard about for a long time. And those talks always start with dark field microscopy. Well, I'm not going to talk about dark field microscopy because almost nobody does it, and there aren't sort of suitable tests. So let's go back to the real world and talk about serologic tests for syphilis, which come in 2 different types. Non-treponemal tests, which in fact are based on the fact that an antigen refined, at least in the United States, from cow hearts made of cardiolipin, lecithin, and cholesterol happens to cross-react with antibodies to Treponema pallidum. That observation has been turned into a highly reliable quantitative test for syphilis. More recently, however, people have begun actually screening with treponemal tests, which are actually defined from the Treponema pallidum antigens. I'll talk more about that momentarily. I get calls every single week about interpreting serologic tests for syphilis, and it's always made me wonder why. And then finally I realized that part of the reason is that we use these tests for 3 different purposes, and the difference in the setting in which they are used changes the way we use the information we get. So these tests are used for screening. That's part of what keeps the blood supply safe. That's done looking at high-risk populations, trying to detect otherwise unexpected disease. We use it for diagnostic testing when we have a patient like some of those with the pictures that I showed before, where it's used to confirm our tentative clinical diagnosis. And then finally, we use it also for monitoring the outcomes of therapy. And because the serologic response to infection tends to occur slowly, that can be very challenging and frustrating for clinicians. A quick comment on enzyme immunoassay serologic tests, these treponemal tests that are being used, at least in North America, increasingly for screening. The reasons they're used widely for screening is because they're cheap, they're easy to do, and the laboratory gets paid the same amount for doing one of these tests as doing tests that cost more time and money to actually perform. The problem with these is that we have limited data on specificity, and they don't work in some populations. One of the populations where this algorithm in which we screen with this treponemal test, and then if people have a positive test, go on to do an RPR, is that some of our populations, including the populations that are served by many people in the audience, already have had syphilis. And these tests are positive from there on out. In our HIV clinic in Birmingham, Alabama, 14% of patients walking through the door have had syphilis in the past. So why am I going to do a test that's already going to be positive in 14% of patients to start off with? Screening for syphilis in persons with HIV is a crucial part of their health care, and it's part of addressing the diagnosis that we're talking about. Screening rates have increased somewhat in the United States, but unfortunately, screening rates are still not what they should be. They're somewhere approaching 70% in HIV clinics at the present time. But more important than that is not only are these tests not done as much as we wish they would, and they do play an important role in diagnosing syphilis because of the issue of latent syphilis that I mentioned before, but they're also not done frequently enough. And this modeling study with the data that were created by Ashley Chewett is really very interesting. This hypothesizes a closed population of patients, such as most of us serve in our HIV clinics. And what she showed is that if you screen annually, you detect syphilis, but you do nothing about the prevalence of syphilis because people keep getting infected. That if you increase your screening rate to every 6 months, then you begin to drop your rates. But the sweet spot, the optimal screening rates for really reducing syphilis rates in a closed or semi-closed population like our clinics is to be screening people every 3 months. That creates a dilemma. We've talked a great deal about PrEP today. The problem is that our PrEP work is going more and more and emphasizing how to get these things, getting PrEP to our patients and not having to drag them back into the clinic repeatedly. And yet for the STD world, as we've heard earlier, and as I would hypothesize continues to be correct, we need to be screening more. So I'm not saying that we need to be bringing people into clinic, but I do think we need to be thinking about innovative ways to accomplish that screening. Finally, a few comments on syphilis management as I go through this rapid fire overview. Once again, I'm going to tell you that there's nothing new, that 80 years ago, Thomas Perrin, then the Surgeon General of the United States, told us how to control syphilis. Screening, we do that. Prompt therapy, we try to do that. Identification of exposed partners for testing and preventative treatment, we try to do that. targeted serologic screening. We've given up on premarital screening, but early pregnancy is still the key to eliminating congenital syphilis, and then public education regarding symptoms, complications, and management. And I would hypothesize that, at least in North America, that's one of our greatest failures. Be that as it may, we do this testing and we do our treatment based on stages of disease. Because of early data suggesting that treponemes during the first year or so of infection divide more rapidly than treponemes later in the disease, we treat people with 2.4 million units of benzathine penicillin when we have it. There is a global shortage that was mentioned earlier, with single doses of 2.4 million units of benzathine penicillin. Because we think more mature infections are caused or have more slowly dividing organisms, we treat patients with longer syphilis or syphilis of unknown duration with 3 weekly injections of drug. I'm not sure that's warranted. I'll comment on that as well in just a moment. These are the recommended guidelines. They're not new. In the United States, benzathine penicillin has been the recommended therapy for treating syphilis for over 70 years. And so things haven't changed. We need to be thinking about alternatives. We also have ongoing controversies about whether this drug, benzathine penicillin, is as good in persons with HIV as not. These are data from a randomized clinical trial done in the early 1990s by the US CDC, in which patients received with early syphilis, that is primary, secondary, or critically defined early latent syphilis, were treated either with 1 injection of benzathine penicillin or 1 injection of benzathine penicillin accompanied by 2 grams of amoxicillin given 3 times a day with probenecid to mimic the serum levels that we accomplish with high-dose IV penicillin. Patients were followed at 3, 6, and 12 months, and the bottom line was that this study proved pretty convincingly that giving more penicillin did not change the outcome of therapy. It did not address the question of whether a longer duration of therapy would accomplish what we're trying to do. In addition, this had a fair number, about 80 patients who were HIV infected in the study. And at the end of the study, again, there was at least no significant difference in the response rates between persons with and without HIV. And it's based on that that we do not change our recommendations. There are still important questions. We know that about 1 in 5 patients treated with early syphilis will not attain the serologic response to therapy, the 2-fold dilution in RPR titers that we're seeking. That's a problem and a challenge. Many of the patients we deal with have latent syphilis, early or late latent syphilis, and what we recommend for patients with latent syphilis of unknown duration or long-standing syphilis is that same dose of benzathine penicillin now given 3 times. But once again, I think this is one of those areas where there are as many questions as there are answers. In the next slide, I've summarized the world's data from randomized clinical trials on the treatment of late latent syphilis. So again, this is an ancient disease. There's there are no more slides. That's it. There are no data. This is this is an ancient disease. Everybody is familiar with the name. Many clinicians are not familiar with the disease. We have many questions, and when I look with awe at all that we've learned about HIV during the 40 years that this epidemic has proceeded, and then I think about how little we've learned about syphilis in the 140 years since we started studying this disease, it sort of reminds me that there's still lots to be done. Thanks for your attention.